Welcome to today's webinar. Good afternoon, good evening, and good morning to our audience from Asia. My name is Jianan Yang, and I'm the postdoc fellow here at the Asia Health Policy Program at the Shorenstein Asia Pacific Research Center. Welcome to today's PKU Stanford Joint Webinar on Asia Health Policies. And today we are delighted to have Dr. Andreas Landmann here talking to us about the information barriers to social health protection in Pakistan. And as you can tell, we have the pleasure of inviting Professor Landmann to visit us in person at Stanford today. And thanks for coming over. It's a long trip from Germany, we all know. A lot of his work investigates insurance in low-income countries with a special focus on health. In particular, he analyzes different impact evaluations on health insurance provision in Pakistan. Additionally, he is interested in decision under risk and uncertainty, as well as pro-social preferences. He conducted several large-scale impact evaluations, randomized control trials, and behavioral experiments in the Philippines, Germany, Vietnam, China, and Pakistan. And all of them include primary data collection. Prior to joining the FAU, he held research positions at the University of Göttingen, the Paris School of Economics, and the University of Mannheim, from where he also holds a PhD. So as usual, we will have Dr. Landmann talk to us for about 40 to 50 minutes. And for our audience, if you have any questions for our speaker during the talk, please use the Zoom Q&A function at the bottom of your screen, and I will come to them at the end. And so without further ado, Dr. Landmann, why don't you take it away?
Oh, thanks a lot, Jianan, for the very kind introduction. And I'll do my best that my talk is a bit more exciting than the first 10 minutes that we had to spend in silence. And let me start jumping into my presentation right now. I hope you can see it, and I hope you can actually hear me well. So I was asked today to talk to a more broader audience. And so what I'll try is I'll describe Pakistan's journey towards social health protection with a focus on information problems of the beneficiary population, awareness challenges. And yeah, I'll mix in results from my research, and in particular, we'll focus on two papers that deal with limited information. So yeah, let's get started. I probably don't have to convince many of you that access to quality health services is a notorious problem in low-income countries, that this is often due to financial constraints, and that because of that reason, universal health coverage has become a global priority, with the access to essential health services becoming also part of the Sustainable Development Goals. Now, social health protection can be seen as exactly one way to reduce financial hardships and to achieve universal health coverage. So it's not surprising that in line with this global priority, a lot of countries in the last 1 or 2 decades have implemented large-scale social health protection reforms. And here you see an overview of countries that have implemented some of these reforms between 2006 and 2011. And you can see that it's really a lot of lower and lower middle income countries around the world. And what's interesting is that of the 1.6 billion people affected by these reforms, 1.4 billion actually come from South and East Asia, which aligns pretty well with the focus of this webinar. So when we look at the list of countries that have implemented these reforms, then this is really a list of the largest Asian countries in terms of population. And I think you also had talks, for example, on India here already in this webinar, which are pretty exciting. So now Pakistan joined the ranks of these countries with a little bit of delay. So they started implementing their so-called Sehat Sahulat Program in 2015-16. And this is really the program I'm going to talk about today. I want to describe you, first of all, the situation before the introduction very briefly. I want to describe you the Sehat Sahulat program, and in particular its challenges related to beneficiary awareness. I want to show, related to these challenges, I want to show you a first paper that shows the role of education under this limited awareness. And then we also very directly in a second paper tackle the issue of uncertainty in healthcare decisions that's created by limited information. So we want to understand better the role of uncertainty for healthcare decision making. So that's the program for today, and let me jump in right in the situation until 2015, before the introduction. So a couple of indicators on Pakistan at that time. So we're talking about a country of roughly 200 million people, most of them still living in rural areas, a lower middle income country with very high out-of-pocket expenditures for health. So we have around 90% or almost 90% out-of-pocket expenditures for health. And this is the reason for this is that social health protection, social protection in general is almost non-existent. So we have less than 2% of the population being covered by some form of formal insurance. The public facilities, public health facilities, which are supposed to be free, are chronically underfunded because the government spends less than 1% of GDP on health, which is relatively low. So that means that the public facilities are lacking, for example, access to medicines. They are lacking also staff, which means that to actually have access to quality services, people need to go to the private sector, which obviously operates at higher costs. So all this leads to the fact that health events are the largest source of financial risks for households on average in Pakistan. That's something that we see coming up all the time in the surveys that we ran repeatedly when we asked for sources of financial risk. The first ones to really tackle this issue, particularly for lower income households, were NGOs and microfinance providers. And I want to highlight in particular the role of the National Rural Support Program of Pakistan at that point, because they were, in some sense, the pioneers of this. NRSP is an NGO which does social mobilization for communities and households. They provide education and a lot of services for the mobilized households, and they are reaching 2.5 million households, and it's really a large NGO, and they are also the largest provider of microcredit in the country. So what they did since 2005, they started bundling to their microcredit program a hospitalization insurance policy for the credit client plus spouse. So that was the first step. But then they also piloted several voluntary insurance schemes for the dependents in the household, so to cover basically the rest of the household. And here's an overview. Pakistan and the first pilots they did, and I was involved already at that time as a researcher, is an RCT in the city of Hyderabad between 2009 and 2011, covers 2,000 households. And I published 2 papers on this in the Journal of Health Economics and Journal of Development Studies, where we were able to show that the financial protection offered by this hospitalization insurance helps to reduce the need for child labor, which is actually a very desirable social impact. Encouraged by this, we designed another larger scale randomized control trial in rural Punjab. That's with about 7,000 households in 500 villages, where we looked at sustainability of these policies. So is it possible to offer this hospitalization insurance sustainably? And what we found out there, this by the way, coming out in July and the AHA applied, what we found out there is that if you offer hospitalization insurance to individuals, you have adverse selection problems. So in particular, the more unhealthy people select into the policies first. and that makes it hard to offer them sustainably. Now, fortunately, there's also an easy solution for that we also piloted, and that is bundling household at the group level. And we see that really substantially mitigates adverse selection, and that makes the policies actually sustainable. So it's possible to recover costs through the premiums. So again, an encouraging news. Now, around that time, when we ran that pilot, also the government became active and started implementing its Sehat Sahulat program. They started in the northwest of the country, in 4 selected districts of Khyber Pakhtunkhwa province and in 1 district of Gilgit-Baltistan. And that was the provincial government starting to cover the first 20% of the population, about so 21 actually, and they covered also hospitalization events in a way very similar to the insurance package that was offered by the NGO. So they covered services provided by public and private facilities, which needed to be empaneled. So empaneled facilities are those that have a contract with the insurance provider and where the rates of the prices of services are negotiated. Soon after this provincial program, also the federal government started implementing the federal Sehat Sahulat program in selected districts at the national level. So we see that the Sehat Sahulat program really started expanding rapidly, and that is something I will show in the following slides. But one more thing that I want to note here is the role of the German Development Bank, which really supported the social health protection initiative in this very initial stage of the first 5 selected pilot districts, and they keep supporting the social health protection initiative until today, and also collaborate with us as researchers and support our research. So here on the following slide, you see a table showing the expansion of the policy. So you see in Khyber Pakhtunkhwa, initially it's 4 districts covered, 20% poorest. So that was about 100,000 households. Now, only 8 months later, the provincial government decided to extend that to all districts in KP and half of the population already. So that basically extended this to more than 40 million people. And then another few months later, it was extended to 2/3, about 2/3 of the population. Then this remained more or less stable for 2 years. And then in 2021, amidst the COVID pandemic, they decided to roll this out for the whole provincial population. So just as a reminder, this only covers hospitalization, not outpatient events, not ambulatory services. Here is an illustration of the expansion, of this rapid expansion from 2016 to 18. So you see it starts in some districts with a limited intensity. So this shows the share of enrolled as a fraction of the population. So we're talking at the beginning about 10–20%. Now then more and more districts are coming in, and that's all Khyber Pakhtunkhwa. And then you see in 2018, like 30, 40, 50% of the population being enrolled. That's a little bit at odds with the table, right? The table says like should be 2/3, which is the policy goal, but that's not what the administrative enrollment numbers show here. So we can also go to the national perspective here. That's the whole country. And here you see the Khyber Pakhtunkhwa province, where most of the action is happening. But you also see in selected other districts around the country, you see some districts have this program as well. And what you see on the right-hand side here is the utilization. So this is annualized utilization. Basically, the claims happening per year per 1,000 enrolled. And you see that also varies quite a lot. across districts, but this is in the range of maybe 5 claims per 1,000 enrolled. And that doesn't seem like very much, right? And that's also clearly below expectations, below what the actual calculations actually had in mind. So you see already here that maybe in terms of utilization, there are some barriers. Now, I was lucky enough to be part of this as a researcher right from its outset. And maybe at that point also a note on the research team. We're still looking at this with also local partners from the Kaiser Medical University. We also have global health researchers from the Institute of Global Health in Heidelberg on board. So also quite some interdisciplinary team, and also, of course, my team. We are closely working with the German Development Bank. We are working with the local Department of Health and the implementation consultants, and that really also helps us to have administrative data that you will see throughout this talk, and you have seen already. Now, we started out with a short-term impact evaluation of the initial pilot program in the 5 districts, and this is a panel from 2015 to 17 with 6,000 households, and that revealed that there is a substitution from public hospitals towards private hospitals that are now covered as part of the scheme. And we see no overall effect on hospitalization and out-of-pocket expenditure at that point. We continued and did in 2019 a smaller study on the bottlenecks to utilization, because we saw already by then that this is a problem. And that revealed that there is a lack of detailed knowledge on the program. For example, that they have to bring their Sehat Sahulat card, and we tried to tackle that through some SMS campaign, which also resulted in slightly increased utilization. Then we are still, or we are having an active panel of beneficiaries in the field since 2022, and we also did a phone survey follow-up on the initial household panel also last year. And the interesting thing is that information and awareness problems keep coming up all the time in all these exercises that we did. And I want to show you this in this table with figures from the household survey in 2017 and in 22, where we asked for the awareness in terms of the insurance concept, or the concept of insurance overall, then the awareness about the existence of the Sehat Sahulat program, and the awareness about own coverage, as well as the question whether they ever used the Sehat Sahulat program. And please note, all these respondents here are officially enrolled. So we really focus on those people that are officially enrolled. And what you see, and what is quite concerning, is that, well, beyond the fact that the concept of insurance is not universally known, that there is a quite substantial share not being aware of the Sehat Sahulat program at all. And what's worse is that even less people are aware of their own coverage. And in the phase of the pilot program, still quite a lot, 72% of the respondents were aware, but in 2022, it's only a third. So that clearly shows that there are some problems. And what is more, that people in particular have problems to know the details about the program. For example, they need to know that not all the facilities are covered, but for example, primary care is not covered, right? It's hospitalization only. So it's secondary, tertiary care that's covered. And also not all the facilities, not all the hospitals are covered, but only those who are in panel. And really many people lack beyond the general awareness. Even those who are generally aware, they lack the detailed knowledge. Similar concerns were also raised by stakeholders, that utilization is below expectations, and also the awareness problems were also seen. And here what you see on this slide is that if you correlate the awareness numbers with the fact that the respondent has some primary education, we see very strong correlations. So here, what's particularly important is the awareness of own coverage, right? That is really substantially and highly significantly related to primary education, and whether they ever used it, at least what they state, that's also highly significantly related. So, by the way, just to note the importance of having some primary education, we're talking about a sample where only 35% of the respondents have at least some primary education. And that's because we are really focusing on the poor that were the initial beneficiaries of this program. Okay, some further insights. Yeah, I'll skip this. So what we really see is that awareness problems are a big issue, that the navigation of the system is not automatic, that it's not easy for these households to navigate the system, and might be a particular problem for disadvantaged households. This really motivated us to look a little bit deeper, and this is where I get into the details of these two papers, to look at first the role that education plays to overcome these awareness and information barriers, and then also very directly look at the role that uncertainty plays and limited information plays for healthcare decisions. So let me jump with this right into this first paper, which is entitled Education and Inequities in Social Health Protection Programs, Evidence from Pakistan. This is joint work with a PhD student of mine, Vendela. And yeah, there's several kind of perspectives from which you can look at this. The one perspective is that education per se is already a major determinant of socioeconomic status, right? And whenever the ability to use the program actually depends on this, then you have an implicit inequity in this program. In a program that's actually supposed to be pro-poor, right? That's not the sense of such programs, that education is a barrier to this. Now, the second aspect to it is that if education really helps to navigate the system, and this highlights something. It highlights that formal coverage is distinct from effective protections, that there is a whole process to coming basically from formal coverage to effective protection. And overall, we hope that a better understanding of this helps to, first of all, design and target improvements for beneficiaries. So what do we know about the role of education in the insurance context? Well, we know from several studies that education increases demand for insurance, also in lower income country contexts. This might be something that in this setup is not so relevant, because we're talking about publicly funded hospitalization insurance where, willingness to pay is not the issue. But there's another thing that's interesting, that education seems to increase the understanding of insurance policies. That's maybe one interesting channel. And what we've also seen in looking at the literature is that, to the best of our knowledge, there is no study relating education to the ability to use policies once you are actually enrolled, because somehow often it's seen, okay, you're enrolled, then you're covered and everything's fine. But this doesn't seem to be the case always. Now, at the same time, there are good reasons to believe that there is a relationship between the two. So first of all, there are studies showing that education improves reasoning, decision-making, so dealing with complex situations. Then there's also something that we should keep in mind at that point, that education and health are very directly related. So education improves healthy lifestyles, also preventive health care, and in general is related to better health status, which then also changes the need for hospitalization. So there's a couple of channels, and on this slide, I want to give you a bit of an overview, like a bit of a theory of change, like through which channels education might affect the utilization of the program. So we have education being related to cognitive skills, non-cognitive skills. That might actually help people to reduce medical uncertainty. These cognitive skills improve cause-effect thinking and memory, and improve insurance literacy. All of which might help people to actually, use these benefits. Then there is a return to education, right, in terms of income. So that's classical economic topic. So you should increase your income through education, which might help to reduce or improve the affordability of like side costs, like transportation costs, and in general reduce financial uncertainty, which also should help to be able to use the policy. And then finally, there's this health channel that I mentioned, right? Better preventive behavior, better health behavior, and all that, reducing health needs. So basically, improving health status means that the need for hospitalization should be actually reduced. These are channels to keep in mind. And let me come back to these two perspectives that I mentioned in the beginning, right? We had this inequity perspective on the one side, and we had this role for navigating a complex system on the other side. So from an inequity perspective, we would be interested in all those channels, right? It's just a simple descriptive question: who gets most out of this program? And if it's the better educated, then it's not in the spirit of this. So all the channels might be important. But if it's about the role for navigating, then this might actually speak for controlling for health needs, which might be different. So this is really the question, like for two people who both have a health need, is the one who's educated better able to kind of navigate through that? And that would speak in favor of controlling this away. So with that in mind, let me turn to the empirics, because I think we have quite some nice features here for the empirical analysis. First of all, we don't have to rely on self-assessed usage, but we actually have admin data on the claims, on the universe of all claims, actually. And we can link that to our survey data. So we can basically see whether the households have used the policy over the course of time. And we can, at the same time, control for a lot of potential confounders with our rich household survey data. So what we basically do is we relate, or we regress the fact whether a household claimed between 2016 and 20 on an indicator of household level education, because we can only link the claims on household level, unfortunately. So we need an indicator for household education, and that is, in our case, whether someone older than 16 has at least some primary education. You've seen that primary education has came up before as a significant determinant of awareness. So at least some primary education of someone seems to be the issue. And you might think, okay, at least someone in the household should have that, but it's actually only 70% of our sample who has, at least someone. And then at the same time, we have other control variables. We control for location, fixed effect, basically distance to the hospital, and also when they became enrolled. Remember that the poorer households became enrolled earlier, so that's something to control for. So let's quickly look at the results. And what we see here is that there's about 2.5 percentage point positive effect of this education indicator on being able to claim. So, and that's relative to the 30% average, that's about a 20% increase. Yeah. And that effect actually increases once we focus on those people that at the baseline, so before the introduction of the scheme, had reported some unmet health need. So that's in the spirit of, controlling the health channel away. So we're focusing on those people who really have a health need in their household that's unmet at baseline. And for those people, the effect of education actually comes out way more strongly, even though we're talking about a sample of only 760 households. And yeah, that is definitely, quite a strong effect. Now, you might worry about limited precision here, and we also do. But fortunately, we draw the sample for this household survey based on census data from the region. And the census data actually has all the variables in it that turned out to be significant in the regression. So in particular, we have the household structure, we have the age structure, we have then, of course, also indicators of education for all the members, and of course, location and everything. So actually, all the variables that that turned out significant are in there. So why not just use that? Well, we're also able to link the admin data to that, and yeah, just run it with 25 times the number of observations. So that's nice. And what happens is exactly what you would expect. We get a point estimate of 2.3 percentage points, which before was 2.5, so very close, which is clear because basically a random sample of the census should deliver on average the same results, but with a precision that's highly improved. So standard errors decrease by like the factor of 3 to 4. So we now get highly significant effects, and we can also test for the effect of female education and male education in the household separately, and we see that both actually seems to play a role. So yeah, you might still worry about causality here, right? So we might have some spurious relationships nevertheless, some uncontrolled confounders. So that's why we also include in this paper a causal exercise, an instrumental variable exercise where we collect school construction data on 15,000 public schools constructed in Kabupaten, and use that as an instrument for education in the style of other papers like Duflo in Indonesia. And we can also link that to the census data, so we have sufficient number of observations. It turns out that the instrument is strong enough only for female education because the male schools were built too early to have some untreated people left. So the male public schools were built relatively early. Female schools were built later. And so we have actually in our sample some untreated women so that the instrument can actually work. What we see is that the effect is really confirmed of female education and comes out even more strongly. So, we basically see that education really plays a role for navigating this, and that is per se interesting. But we can also study, that's with this idea in mind that education helps to overcome a complex system. But we can also study heads-on what a complex system actually means for healthcare decisions. And that's the other paper. That's entitled Financial and Medical Uncertainty in Healthcare Seeking. That's joint work with Alina, a PhD student of mine, and Lisa, a postdoc at my chair. And motivation is that we see a lot of information, awareness, and protection gaps in this scheme, and all this aggravates uncertainty. Now we can see how other factors like education might help to overcome uncertainty, but we can also directly study it, right? So that's what we want to do. And I think that through this, we actually contribute to increasing or improving the understanding of healthcare decisions, because many economists in particular have sometimes a little bit of a simple understanding of these things. And yeah, I want to show you where we think it's too simple and how, and the following. And to do that, I want to take you through the healthcare seeking process. So imagine that there is a health shock coming up and you're unsure, like, should I use healthcare or not? Then the first question is really, will it be worth it? Like, will it substantially improve my health if I go? Then the next question is, can I afford it? If both questions are answered with yes, then you go and you seek healthcare. If one of these questions is answered with no, then you neglect healthcare. So that's a classical, like, cost-benefit analysis, like economists would model it, right? And how insurance comes in is that it helps to answer this affordability question with yes. So this is then where what we call more comes in. Once it's covered, you increase utilization. So how does uncertainty come into this? Well, it comes in at this point. Will it help me? Well, you might be uncertain about that because you might not know what you're having as an illness. What is it? And also not sure about the effectiveness of care. Yeah. That's something that is at least as a risk still modeled in the literature, less so as uncertainty. But what's definitely not modeled in the literature is the cost uncertainty. And I was talking the whole time about protection gaps and that people don't know what's covered. And what is that? That's cost uncertainty, right? And that might have implications for whether how you answer the affordability question. Also, I want to point to the fact that medical uncertainty and cost uncertainty are directly related, because if you're not knowing what type of illness you're having, and different illnesses have different cost implications, then medical uncertainty creates cost uncertainty. So for us, this double uncertainty is really important to understand. Let's look at the literature. So since the early paper of Arrow, 1963, medical uncertainty is really recognized, both in terms of uncertainty about the illness and uncertainty about the effectiveness of care. And as such, also extensions of the Grossman model of healthcare investment have included medical risk, in particular, like the probability that the health investment might be effective, and less often so, but still some do it, or some rare papers do it, also include uncertainty about this probability, so that you're not sure how large this probability actually is. So that exists. But what doesn't exist really is the uncertainty about costs. So that is something that we'd like to contribute to and show the relevance of this also. We also relate to the literature measuring subjective beliefs and uncertainty, but I'll show you along the way a little bit how and what we exactly do. Just a word on our theoretical setup here. So we model healthcare choices by basically people assigning a valuation to different care options. And this might be, so care options, which might also include doing nothing, right? And what you essentially care about is the health status that you're having. You might have good or bad health status, and the cost that you face for a certain option. All that kind of creates an expected utility for a certain provider K, which certainly should increase with the probability to reach the good health state. So the effectiveness of care, and it should decrease with the costs that you face at a certain provider. Now, both of these things might actually end up being uncertain. They might not be sure about the probability that it substantially improves health status and the cost. So they might depend on an unknown cost probability state gamma. That means that you can calculate this expected utility for each gamma state, And then you have to aggregate this and basically through a valuation function, and that what we use here is the smooth ambiguity aversion model of Klibanov et al. So KMM, smooth ambiguity aversion. So where we can integrate a range of different ambiguity attitudes and also risk attitudes, of course. So yeah, I don't want to go too much into detail. I've worked on this also in the insurance context with Christian Biener, and that certainly helps. What's really clear from this model is that if you have a higher assessment of the average probability, of the expected probability that an option increases your health, then this should increase the valuation of this option, and exactly the other way around with costs, of course. What's less clear is the role of uncertainty here. It's really difficult to formulate analytical solutions, so we resort to simulations, and two types of simulations. The first type of simulation really shows and motivates how the double uncertainty might lead people to neglect otherwise sensible healthcare decisions. And that is like we simulate a situation where like service provision at a high quality facility at higher cost would really make sense. But the fact that you add cost uncertainty and also effectiveness of care uncertainty leads to the fact that you neglect this, that you do nothing or go to a lower quality provider in this simulation. It's basically because you're afraid to spend a lot of money for nothing at the end. Yeah? And if cost is an issue for you, then this is a relevant thing to think about. Now, the second type of simulation is really calibrated towards our empirical setup, which I'll go into a little bit later. So we really calibrate all the parameters we have there, and then play around with these uncertainties under these conditions, because we want to really derive hypotheses for our empirical application. We have already the two hypotheses about the role of the expected probability to get better and about the cost. That's clear. But what we see in these simulations is that uncertainty about the probability to get better and about costs both decrease the valuation of this care option and also then, of course, the probability to choose that option. So now we have basically all our hypotheses for the empirical application set. Okay, now we get to the empirics and first of all, how we actually measure uncertainties, and that's a whole task on its own. So you've seen this care-seeking process, right? So we make people walk through that hypothetically. So we give them hypothetical health scenarios, so-called vignettes, and then we assess. They have to individually assess it, and we measure their assessed medical and cost uncertainty, and then also let them take hypothetical healthcare decisions. Why do we do it hypothetically? Well, you can never do that in an actual health crisis. It's totally unethical. We can't do that. And if you do it afterwards, then all this assessment is biased by the actual decision. So for us, it's the cleanest or most ethical way also to do it. And how do we measure medical uncertainty? Well, so we first of all, we base ourselves on established literature, de la Ronde et al. 2022. So we assess or we get an overall expected probability to get substantially better at a certain healthcare choice. And then we get a minimum and a maximum possible probability. And the range here constitutes the uncertainty. Yeah. So that's the first thing. And then what about cost uncertainty? Well, again, we relate to established literature, in particular Atanasio and Kaufman, that have developed a method to gain a measure of uncertainty of unknown monetary values. Maybe I just show you this directly in the backup slide. So basically, we ask them for a minimum and maximum possible cost, compute the midpoint, elicit the probability to be in either one of those bins, yeah, and then we just fit a distribution. In that case, a triangular distribution. You can play around with that, but doesn't change much. And based on that, you can calculate an expected value and a standard deviation as a measure of uncertainty. Okay, so these measures we gather for different health situations. So we have 3 types of vignettes. The first one is a heart disease scenario, where basically the symptoms of a heart attack. Yeah. The second is a belly pain scenario, where you get symptoms of appendicitis. And the third one is a light fever scenario. And in each of those scenarios, they have to give us these assessed, they have probabilities to get better when choosing these care options, different care options, and the costs, both for primary facilities and also for hospitals, both public and private. So these are the relevant choices for people in this region. We did that study with a sample of more than 300 people in 4 districts of Kayopaktongkwa. This is really the poorest of the population. And yeah, I jumped directly into the results. These are the expected probabilities on average to get better with the different health scenarios at the different facilities. And I try to walk you quickly through this. So what we see here is that in public primary facilities, these probabilities are assessed the lowest. So private facilities are assessed higher. So basically quality of care is assessed higher. And then if you go to hospitals, that even becomes slightly higher. And again, highest it's at private hospitals. So basically a measure of quality of care. Yeah. Question is like, how biased are these self-assessed probabilities, like relative to an expert opinion? So a couple of things to note are that with a heart disease, like with a heart attack, and also with appendicitis, you should really go to a hospital. So basically, these these primary facilities should not help you. So here, there's clear bias in the probability. So that should be lower, at least for these 2 health scenarios. And in the light fever case, there's actually a very high probability that just cures itself and goes away. So irrespective of the health provider, you should have a way higher probability. So there are clear biases in these self-assessed probabilities, but at least, you know, the patterns are somehow make sense. So what about the costs? Here again, we see like stark differences between provider types. We see that in primary facilities, of course, it's cheaper, but that private care is just way more expensive. And of course, the most expensive you see here is private hospitals. And with light fever being always the cheapest option, so that makes sense. What we can do to assess the plausibility of this is that we can just compare this with our survey data, where we also have detailed information about the costs that they face under certain conditions, like for those households that had these problems. And we can really see that these cost estimates make a lot of sense. So they are really in the same range as the costs that are really faced. So here we can say, okay, these numbers make sense. But what about uncertainty around these numbers? So we see that the medical uncertainty is really high. So the difference between the minimum and maximum probability is on average 45 percentage points. So it's really a huge range that they give us. So there's quite a lot of uncertainty here. What about cost uncertainty? The cost uncertainty is really proportional to the costs. So the higher the cost, the higher also the uncertainty, which means that it's particularly a problem in these, you know, private hospitals in particular. So where the cost is high, there's an additional burden of high uncertainty. Okay, let me also just go into the healthcare choices that people make. And I give you the one for the heart disease. And here we basically have people focusing on two options: private primary care or public secondary, so public hospitals. These are the relevant choices. Yeah, like private hospitals are really a no-go because of the huge costs, apparently. Now the question is, can we explain the choice between these two by the parameters that we measured before? Yeah, by these cost and effectiveness of care estimates. So basically, we can regress which option they choose on, the assessed characteristics of these facilities. And that's what we actually do. And we have clear hypotheses now how this should work, right? And what should happen. So if we do that, here what you see is that we explain, for example, the choice of the public secondary facility by the difference, the relatively higher probability to get better at public secondary facilities. And this is really totally in line with our hypothesis. So the higher your your probability to get better at the public secondary facility on average, the more likely you are to really choose it. So that makes sense. What about cost? So the higher relatively the costs are, the less likely you are to choose it. That makes sense. But unfortunately, we lack precision. Now, what about uncertainty? That's really very interesting for us. So here, the higher the uncertainty relatively, the lower the chance to choose it. Makes sense, according to our theory. And the higher the cost uncertainty relatively, the lower the chance to take it. Makes sense, according to our theory. So you see that, and this is just the data from the heart disease scenario. We can do that, of course, also for the other scenarios. We can also basically do, instead of the differences in probabilities, like the individual probabilities and so on. So we have a couple of empirical choices here. So we lack, of course, a little bit precision, but really the vast majority of coefficients really go into the right direction, and all the significances basically also go into the right direction. So basically, this is supporting the way we think about this, supporting that uncertainty is there and plays a large role for the decisions. And what we are currently doing is we're refining this concept. We're preparing another round of data collection with way more data for improved precision and with improved tools. And also we're planning an intervention, so basically somehow tackling the uncertainty and checking whether that can affect utilization decisions. So that's the way ahead. Let me now wrap up and conclude quickly. So we've seen that Pakistan has really made impressive progress in terms of, particularly in terms of absolute number of enrolled people. But awareness information problems are there. So it's important to actually create universal awareness. So one needs to be more effective in that. We've also seen that in this context of limited information, uncertainty is important for healthcare decisions. It plays a role. So guidance in terms of financial and also medical implications, and ultimately at the same time, would be important. Something that's also relevant beyond Pakistan is maybe kind of just the way you think about social health protection. It's not enough to just have it, right? You also have to think about how people navigate it. And yeah, that's something really important. Then coverage gaps, right? We're talking about a hospitalization insurance here. So the elephant in the room is, of course, outpatient care. So ambulatory services, it's a huge gap in the protection. And the more gaps you have, the more uncertainty you have also, because the less sure you can be that your case is actually covered. So here to reduce this, closing the coverage gaps is really a good idea. So yeah, that's basically it. Thank you a lot for your patience and your interest. I'm really looking forward to your questions, and sorry also that we had to start late. Yeah.
Thanks. Yes, indeed. I feel like a lot of is involving the
do you have it open?
Yeah.
Okay.
Right. So let's continue. In general, I just feel like in the low-income countries, as people advocate for the universal health coverage, I think there's a lot of questions associated with the provision of this kind of health insurance, right? And also, like, I think I'll have a few questions of myself, and for our audience, like, feel free to type your questions in the Q&A function if you have any. I think, like, as we've been chatting a bit before, I'm like fascinated by this idea of uncertainty in the healthcare, like production function in general. So I'm very interested in that. But like before that, I just have like a several like bigger picture questions regarding the health insurance provision in Pakistan or in low-income countries in general that I want to have your opinion on. So first, I know that you've worked on the adverse selection issue in the health insurance domain. So I think like, and one argument about that is if we have a government provision of insurance, if we mandate or have universal healthcare coverage, this issue will get like largely resolved. So now that Pakistan has implemented things like that, do you feel like the adverse selection is not a big concern anymore? And yeah, how do you feel about that in Pakistan context?
So yeah, sure. With like a public provision of insurance where everyone is enrolled, you by definition cannot have adverse selection anymore. So this is certainly a problem for market-based insurance. What's more of an issue in terms of incentive problems is then the moral hazard issue. I think there is a fine balance, right? I mean, I am advocating in my talk implicitly for that utilization is a good thing. It is a good thing to some extent because I mean in the context we're talking about, it's really that the poor people have not enough access to healthcare. That's clear. So, but maybe at a certain point, moral hazard is a thing to actually look for, and you need a sufficient gatekeeping and everything to make sure in public health insurance that this doesn't create sustainability issue.
Right, indeed. I think as we expand healthcare coverage in developing country settings, we're going to face a lot of issues that that's been frequently discussed in the U.S. healthcare context or other developed country contexts, right? And then like another like bigger picture thing is, we were talking about providing health insurance to the poor, but like how much do we think the like healthcare provision is a constraint in like people utilizing the health insurance or getting access to care in general, especially in those kind of like resource constrained settings, for example, in Pakistan?
Yes, I mean, provision is something that I have largely ignored in my talk. And of course, this is also a huge issue. Implicitly, I've talked about it that it's a problem in the public sector, right, where quality is low and they're understaffed and all this. So now this move towards health insurance is also a bit of a paradigm shift, where you basically give the money and the resources to demand, and they can then basically go wherever they like. They can go to the private sector, which should have at least provide better services, and should then also optimally not only the private sector, by the way, there's also a little bit of financial retention of public providers, so they can keep part of the money that they basically get through provision of services. So on both sides, there's incentives to actually have more resources, maybe invest those and alleviate these supply side constraints. But there is no arguing that yes, there are definitely a lot of constraints in Pakistan currently. And this is, of course, an issue, and I just don't have time to talk so much in detail about it.
Yeah, sure. So that I think just highlights there are just so many important issues in the healthcare domain in developing countries in general. And we have seen evidence from other countries like Indonesia or India, where people say document that even though the government is trying to provide health insurance to its population, there's limited take-up and utilization. But that probably also, I think, highlights the importance of how we design this kind of public health insurance program, right? And probably it's a dynamic issue. Once there is enough demand, there could create competitive pressure for health provider to increase its quality or just increase the quantity of healthcare provision in general. And also the reason why whether we cover inpatient versus outpatient care, that's also an issue of the design of the public health insurance scheme, right?
Yeah, I think that's something I can just support. Maybe a note on it also. What you've seen is also geographically a very different and diverse utilization of the policy. That was the one graph I showed at the beginning. And that has also something to do with hospital density, right? In some places, you just don't find a qualified hospital nearby. So yeah, just have problems to impanel more facilities because there are just no qualified facilities, and empanelment also depends on certain quality criteria. Yeah.
Yeah, great. So I have another question related to the relationship between education and health insurance utilization. So you mentioned two aspects of this problem. One is equity, and the other one is how you navigate the complexity of the system. So can you speak a little bit more of how do we interpret the results you document as the equality part, or more on the complexity part?
So I think the ones that are not controlling for the health at baseline, they are certainly to be interpreted more from an equity perspective. And only once we have the subsample where we can control for health needs at baseline, I think that goes more into the navigation. And yeah, I didn't have time to explain it, but what you see there is again what you would expect, right? So those who are higher educated use it more despite the fact that they have lower health need, right? Once you control for the health need, then it comes out even more clearly. So that's what we see in this limited subsample. Unfortunately, we cannot improve or increase the sample because in the census data, we don't have data on baseline health needs. That's the kind of only disadvantage that we have. But I mean, fortunately, it comes out significantly also in the small subsample. So I would interpret this in that way.
Yeah, I do want to follow up a bit on that. So I'm curious about how we measure the baseline health needs. Is that through surveys? And if that's the case, would we be a bit concerned about that the well-educated are more aware of their baseline health needs?
That's a very good question. So basically, we were measuring neglected health needs at baseline. So just with the idea in mind that there is still a lingering health case in the household. And so the way we asked this is basically whether there was a health event, and then basically whether care was sought or not. And basically we isolated those cases where they named a health event happening, but they didn't seek care. So that's kind of a proxy, of course. It's a rough proxy, but that's what we can do. And you're absolutely right that probably the correct assessment of this might also depend again on cognitive skills. But here, yeah, we don't claim that this is the perfect empirical setup, but it's the best we can do at this point. I mean, in principle, you'd need like qualified medical opinion optimally to really put them on the same health need level.
Yeah, like just the data collection effort is like, I think it's already huge that you put in to study this type of questions. Yeah, and then like finally, I think related to the uncertainty, the second paper that you talk about, I would also think there might be a education gradient in it, right? So have you studied or thought about any like interaction between the uncertainty and education aspect of health insurance utilization?
Again, you're right. Absolutely, that's something we would expect. We've seen in this, we've shown in this theory of change, in this education theory of change, that actually both medical and financial uncertainty should be somehow affected. And that's something we should see in the data. We haven't done it yet because we've focused really on the main hypotheses. We didn't want to overdo the analysis at this point. I think we'll do that, and we'll do that definitely once we have more data to really go more fine-grained in our analysis. Absolutely, yeah.
Yeah, that all sounds fascinating, and I believe it's a like ongoing data collection effort. There's more data available, you'll be able to like get more interesting results out of like this research agenda. And then in general, I feel that like the uncertainty in like healthcare in general matters like a lot for patients' healthcare utilization decision, probably more so in this kind of developing country context because of the low provider quality that creates additional uncertainty in terms of the medical part, right? Apart from like the financial part.
Yeah, absolutely. So, I mean, I think this is something that really motivated this research, that you cannot be sure to have like a high quality treatment in these contexts. You cannot be sure that you're protected financially in these contexts. So this is like probably like the the best case, best like in parentheses for studying this. I think that also in higher income contexts, the uncertainty plays a role. Just ask yourself, like, how sure you are with certain options that this will help, or just uncertainty about probabilities and so on. So you can just ask all these questions to yourself, and you'll see that you'll face often very similar issues. The only thing is that the financial consequences here are usually not catastrophic, right? So you don't have to worry about, you just have to worry more about time, like where you go, and that's more an issue. But there, the financial issues are really devastating, or can be devastating.
Cool, that all sounds great. So I really look forward to seeing your paper from this like ongoing data collection and further analysis that you and your team are going to do. So I think we have already go slightly over time, and I want to thank you again for this fascinating presentation, and also thank all of our audience for joining us today. And I hope to be in touch with you for our future webinars. And hope everyone has a good rest of your day. And we're going to conclude here. Thanks.
Thanks also from my side, everyone.